Good morning. Welcome, everyone. Thank you for joining today's Knockout Opioid Abuse Day webinar, Achieving Racial and Ethnic Equality in Response to the Opioid Epidemic. Some housekeeping items. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for one EMT elective CEU, and the Partnership for a Drug Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers, and this program is eligible for one maximum Category A hour or CEU. PA Planner Dean Barone discloses that he serves on the speakers bureaus of Ethicon and Johnson & Johnson, and all other planners, faculty, and reviewers have no relevant financial relationships to disclose. All relevant financial relationships have been mitigated. And if you wish to claim CME or CE credit, you must do so within 30 days from today's date. After that, we will no longer be able to issue you credit. Today's webinar is jointly provided by the Partnership for a Drug Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the Office of Alternative and Community Responses, the New Jersey Office of the Attorney General, and the Opioid Education Foundation of America. And once again, I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. For those of you who have joined us in the past, you know that in June, in honor of Juneteenth, we like to recognize the possible health disparities that may exist. And so that is why today's webinar, we're so excited to have with us our expert faculty. Dr. Fabiola Arbello Cruz is an assistant professor of psychiatry and director of the health equity curriculum for the Yale Psychiatry residency program. And she also serves as an attending psychiatrist on Connecticut Mental Health Center's Team D and Street Psychiatry outpatient teams. So Dr. Arbello Cruz, we are so happy you are with us today and look forward to your presentation. And I will turn the webinar over to you.
Thank you, Angela. And good morning, everyone. I will say again that I'm very happy to see that in the chat there were a lot of good vibes, meaning like people saying good morning and where they're from. I really, 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 really appreciate that. I don't typically see that, so I really like that. Just for me to be sure that you're seeing what I want you to see, Angela, can you just confirm with me that you're able to see my first slide, which is the title?
I'm able to see your first slide and you are in presentation mode.
Okay, presenter view or presentation mode?
You're in the view that we need to see.
Okay, perfect. Thank you. Thank you. So, for everyone in the room, my name is Dr. Fabiola Arbelo Cruz, as Angela mentioned. And I just want to say right off the bat that I'm an outpatient addiction psychiatrist. And although I'll be sharing historical and research perspective, I will share some clinical pearls and wisdom that I have had from my clinical career, because that's the bulk of what I do. And I just want you all to know that I mainly work with dual diagnosis, meaning people that have psychiatric and co-occurring substance use disorder. And even that, my focus is working with people with severe mental illness and their own health. So just to give you a flavor of who I am as a person, I was born and grew up in Puerto Rico, in Quebradillas, and I moved to mainland US around 2017, and I have been in Massachusetts and Connecticut for the last decade. Really happy to be here, and I want to thank you for bringing this topic to discussion. And before I go to the objectives, I just want to hold space to things that are happening worldwide. I woke up with the news of the earthquake happening in Venezuela. There might be people or not that have been impacted in this webinar, but I just want to hold space to acknowledge that a lot is happening, and my thoughts, if you have any friends or family members that are being affected, or if you don't even know what's going on with them. For today, we have three objectives, and they are discussing the evolution of the opioid epidemic. And I really want to just discuss how we define the opioid epidemic by four waves, which I'm going to get into, and differences that we have seen of how some racial and ethnic groups have been disproportionately affected by each wave. Second, I'm going to talk about the growing role of stimulants leading to more opioid overdose death in particular groups. And lastly, being able to provide context in how not only the drug supply contributes to the overdose death, but how structural barriers lead to some people, well, everyone, but specifically specific population to be even at more risk of overdose risk. And to start, I just want to review with you all, as I mentioned, the evolution of the opioid epidemic in United States. As we see in this slide, which is a simplified representation of the four waves of the opioid overdose crisis in the last 25 years, I want you to know that in the bottom, you have a summary of each wave. And I just want to summarize that the main differences with each wave is a supply of opioids. Wave one, which started around late 90s, was the rapid increase in death from prescription opioid. There was a lot of prescription being given, and that led to increasing overdose death. And that was followed around 2010 with the rise of heroin-related deaths. There are many reasons for that. Many people say it's like availability and also people having it accessible, being a cheaper price, but that become more common having heroin-related death, leading to the second wave of the opioid epidemic. And wave three, which we have seen a lot in public media around 2013 onward, where we started to see synthetic opioids. And just for having common vocabulary in this room, opioid is a very big umbrella term. There are different kind of opioid. There are naturally occurring opioids like codeine, morphine, and there are synthetic opioids, those that are done in a laboratory. Fentanyl is a synthetic opioid, and the rise in availability of fentanyl, which is very much potent than prescription opioid and heroin, as you all know, became the dominant driver of overdose deaths from 2013 onward. And that really caused an unprecedented rise in deaths from overdoses. Now we're talking about 2024, and it started around 2015. We are in what we call the fourth wave of the opioid crisis. And the fourth wave of the opioid crisis has been described as a lot of that involving fentanyl combined with stimulants, namely methamphetamines and cocaine. And that has produced the deadliest phase of the epidemic. I just want to also make sure to highlight, and you can see it in the last years of this graph, like 2024, that there's recent trends of overdose death related to other substances without fentanyl. You can see in the top stimulants with no fentanyl, there has been a rise. Just want you to highlight that. And also xylazine, which is not an opioid, but has been seen a lot as an additive or contaminant to the drug supply, have also increased in overdose death in the last few years, okay? So again, this is just a very, very, very simplified representation of the four wave of the opioid crisis. First wave being prescription opioids, no heroin. The second wave driven by heroin. The third wave driven by fentanyl alone. and the current wave, which is fentanyl with stimulants, okay? And what I want you to take home from this message is that we are in the fourth wave. And as you were able to see, or maybe not at the end, deaths from fentanyl with stimulants are declining. We're seeing that. We're seeing that. That said, not all segments of the overdose crisis are declining. As I showed previously, deaths from stimulants and silencing have not declined. And that's important for us to know, to keep in mind of the people that we serve. Okay? And I was talking to Angela before you were joining. I just want to put a take home point that I can see maybe in the future us looking at the overdose epidemic at a different way. Now we're tracking a lot of overdose death, but with stimulant overdoses going high, we might need to look at other outcome because overdose death is not the only bad news of overdose. There's a lot of people that overdose and do not die. We have already seen a lot of stimulant related negative outcome increasing. For example, substance-induced psychosis has been in the rise. I'm just mentioning that because we need to keep track of how this overdose epidemic is evolving. And we know that deaths from fentanyl are declining. We don't know what's going to happen in the next few years, but we know that there has not been a decline in deaths from stimulants. Moving along, this slide speaks specifically about overdose death by race and ethnicity between 1999 and 2024. And I just want to highlight that from all you can see here, please note that there has been a very sharp increase in racial and ethnic disparities after the first wave. Once illegally manufactured opioids like fentanyl and fentanyl analogs, because fentanyl is not the only synthetic opioid. There are other synthetic opioids like carfentanil and other substances that we're seeing growing in the field. We know that entering of fentanyl led to a disproportionate increase of death in specific group. Black communities experienced the steepest increase during the heroin and fentanyl waves, the death surpassing that of whites by 2020. And for American Indian and Alaska Native communities, it's important to recognize, and this does not show much in public media, that opioid overdose rates rose steadily alongside whites. So it has been on the rise for many, many years, not only in the last 10 years. What happens is that when there are many research being done or studies, it could be at times hard to track American Indian Alaska Native because maybe what they have as a group is a very small number and they might not include in all studies them as a group. And that's a disservice, it's a limitation, but I just want to say that. I want you all to know that American Indian and Alaska Native communities have been experiences steadily overdose death alongside whites since wave one of the opioid epidemic. And they have now the highest mortality rate. You can see from 2020 to 2024, American Indian and Alaska Native having the higher numbers of overdose death. So, in summary, all groups saw progress in overdose death. You can see the right side of the graph having like a downtrend of most groups, but the decrease in rate varied by race and ethnicity, with Blacks still having higher death rates than national average, and American Indian and Alaska Native as well. Okay, Something I want to mention, and I will just be brief, but I want you to know because New Jersey has close to the fourth biggest population of Puerto Ricans. As you can see in this graph, the green line, which is Hispanic, is accounting all Hispanic Latina subgroups, Mexican, Puerto Rican, Dominican, people from El Salvador, Venezuela, everything. When Hispanics are studied as a group, we see that they don't have an increase in overdose death as much as compared to other marginalized groups. There have been researchers that have looked at the Hispanic Latino population and disaggregated data, meaning that they just broke down the subgroups and look at overdose death. And this slide, I just wanted you to know because again, New Jersey has close to the fourth group biggest Puerto Rican population in the nation. Here we're looking at US drug overdose mortality from 2015 to 2019. And the major finding was that when they disaggregated data, Puerto Rican group were higher than any other Hispanic Latina heritage subgroup or Black and surpassed non-Hispanic white population from 2017. So I just want to highlight that because the take-home point is that when drug overdose data, mortality rates data are presented for the Latina Hispanic category overall, the disproportionate high rates of overdose mortality in stateside Puerto Rican is obscure. I just want you to know that. Moving further, here we're looking at overdose death by substance use, by substance and by race and ethnicity. And just I want to highlight to you all that at the top, the four squares in the top, we're seeing overdose death involving opioids, different opioids, right? And in the bottom, we see deaths involving stimulants and silencing. And what I want to highlight is, as I have already touched on, days involving fentanyl with and without stimulant are decreasing but continue to disproportionately affect Black and American Indian Alaska Native. And when we look at stimulants in the bottom, for stimulants specifically, even without fentanyl, there's a disproportionate impact in all years assessed for Black communities. For methamphetamine, American Indians and Alaska Native being disproportionately impacted. And the same for both groups for silencing, okay? And I will get to the next slide some of the ideas why that is, because it's multifactorial. But I do want to mention that specifically for methamphetamine, we know that during COVID and post-COVID, there has been a lot of more drug supply of methamphetamine. And not only that, but more purity and potency of methamphetamine. So that's important to know. And I'm hammering this down. Take home points. Fentanyl going down, still this group having higher national average, but cocaine, methamphetamine, psilocybin are not declining at all. I just want you to know that. And the disparities of how it's affecting marginalized communities are still seen. So what about stimulant? What's going on with stimulants that we know that are affecting a lot of communities in the last decade or more? In my clinical experience and looking at literature, we know that the supply of fentanyl has been contaminated with, the supply of cocaine has been contaminated or have additive of stimulant, leading to people using, could be smoke, snorting, and having accidental overdoses. And there's the reality that some people have intentional use of fentanyl combined with stimulants or heroin, right? So there's people that use it without knowing there's fentanyl, and there's people that are looking for that specifically. And we know that there's ongoing use and more deaths, and that's difficult to see what are the etiology, but I would touch upon on structural factors soon. But as I mentioned, methamphetamine, we're seeing a lot of more potency and availability to supply. And there's still ongoing disparities in access, initiation, and retention of medication for opioid disorder. And there is no such thing as a buprenorphine for cocaine use disorder. There is no such thing now as a buprenorphine or methadone for methamphetamine use disorder. We don't have FDA-approved medication for stimulants, which limits our option of how to provide good treatment. And I just want to plug a point that there are 3 FDA-approved medications for opioid use disorder, and I'm pretty sure you all have heard of them: methadone, buprenorphine, naltrexone. I want us to plant the seed that we know that methadone and buprenorphine are first-line treatment for opioid disorder. Naltrexone is considered second-line treatment for opioid disorder. And the reason why that is we have seen that methadone and buprenorphine do better at preventing overdose death, overdose related negative health outcomes compared to naltrexone. I'm not saying that we should not use naltrexone. It's a good tool to have, but it's important that we tell our people that methadone and buprenorphine have better data for opioid disorder. There will be people that do not want to take medication for opioid disorder. Something I work with communities is to share the message that if MOUD did not work for you, it's okay. That does not mean that it would not work for your neighbor. Stigma is real, and faulty understanding of MOUD is real too. I will get to that, but I think it's a bread and butter for me to hear the following. Fabiola, I don't want to start buprenorphine. I don't want to substitute one drug for another. That's a very common response that I get from folks, or another thing that is quite common for me to hear is, I don't want to go too high on methadone because that means that I'm not doing something right, or I should not need such high of a dose. And for me, that's an opportunity of education. Like for the first scenario that I share, I don't want to use buprenorphine or methadone because I don't want to substitute one drug for another. Something I might say to them is, you're right, buprenorphine and methadone are drugs, are substances. You're absolutely right. Let me tell you how I think is different from street fentanyl. If you take methadone buprenorphine, you take a specific dose. We know what we give you. If you take buprenorphine or methadone, you would treat withdrawal. And we know that if you take methadone and buprenorphine and you use fentanyl on top, you're still protected. Because when I do street outreach, something I encounter is that some outreach worker might think that if someone is on buprenorphine and methadone and using fentanyl, they are not doing well, or they're at higher risk for negative outcomes. But what we know is, yes, they're at risk for negative outcomes, but if they are on methadone and buprenorphine and they still use fentanyl on top, their risk of negative outcome, it could be medical or overdose, is lower. Just want to put that plug in. In terms of the dosing, I always tell people in methadone that when you are on 60 milligrams of methadone or less, for most people, you're only treating the withdrawal. Again, when you're treating methadone with 60 milligrams or less, for most people, because I cannot generalize to everyone, you're mainly treating the withdrawal of opioid. it's not until you get to 80 milligrams or a little bit higher that you treat both the withdrawal and the disorder. And that's an important distinction. Um, so yes, we don't have good medication for stimulus disorder, but we have some that are off-label, and majority of people are not using medication for opioid disorder. And lastly, and very importantly, and that's going to be the next slide I'm going to talk about, we're still not adequately addressing vulnerability in social determinants of health. And what I mean by that is that there are some identities that, and it's not identities, but processes that affect more unfairly specific groups and lead to poor outcomes. For example, with criminal justice involvement, we know that the legal system in the nation has overrepresentation of Black and Latina people. And we know that studies done years ago show that there are similar use of cannabis product like marijuana in Blacks and white, but Black people had more criminal offenses because of possession of cannabis, right? So how that can look like in terms of having higher risk for overdose. Well, someone that is in the legal system will be at risk for having less chances of employment, less chances of fair housing, um, less chances of having access to medication for opioid disorder. And we know that the leading cause of death of people recently incarcerated is overdose death in that first month because people have a different tolerance for opioids. That's just one example, criminal justice system. For housing, for example, we know that the community of unhoused individuals, specifically unsheltered individuals, are overrepresented again by minoritized communities. And minoritized community like American Indian, Alaska Native, Black, Latina represent the smallest portion of the United States. And being unhoused has been a link to not only less access to medications for opioid disorder, but being retained less in medications for opioid disorder. And what I mean by that is if I start today methadone, buprenorphine, I might not be buprenorphine in 6 months from now. Also, people that are unhoused, and this was a study done in 2021, have 12 times higher rates of overdose risk than the general population in the US. So I'm just sharing examples of how vulnerability in social determinants of health lead to risk factors for overdose death. And this brings the topic of structural determinants of addiction. Because as I shared in previous slides, yes, there have been changes in the drug supply over time from prescription opioids to heroin to fentanyl, then fentanyl plus stimulants and other substances. But that is not the only cause for disparities in racial ethnic communities in overdose death. There's increasing research that shows that the accumulation and persistent experiences of marginalization in different systems that govern our lives due to structural racism are root causes of health and ethnic health disparities. Okay. And just to touch on some of the main ones that I think we have much data, how this happens. For example, the first one, there's social, cultural, and economic physical environments that determines my ability and yours ability to receive affordable care, comprehensive evidence treatment. There are geographical areas where there are not much treatment facilities, and there is evidence that not all treatment facilities offer evidence-based treatment for addiction. For example, there was a recent study that showed that specialty treatment facilities, about only 51% of them offer medications for opioid disorder specifically. Yes, opioid disorder. So that determines one's ability to receive treatment, where you live. Second, death of despair, this theory that attributes marked concurrent rise in overdose death, suicide, and alcohol-related mortality to a cumulative cultural despair caused by declining economic opportunity. And that erodes social cohesion, class, and creates racial disadvantage, all that leading to deprivation, hopelessness, that many people could use substance use to cope maladaptively. In terms of healthcare, uninsured rates are worse for communities of color and low income. And that can lead in itself to inadequate treatment of addiction or other chronic conditions. In terms of housing, I already touched on that, but people that are unsheltered are extremely high risk for overdose death. And in terms of racism, because it's very hard to untangle all the tentacles for which racism has impacted our system. Pretty much discrimination had led to a lot of psychological damage in the well-being, racial bias in patients and healthcare providers and policymakers, which has led to a lot of inequitable addiction treatment, right? And trauma has been a common threat in the lives of individuals with substance use disorder and has been associated with risk for substance use. And unfortunately, trauma-informed interventions for patients with PTSD and SUD are not widely available, right? So it's a constellation of things. It's not only one thing, it's multifactorial, how marginalized communities are made at risk to have an addiction, to have worse outcome for addiction, and have more barriers to get addiction treatment. And these points that I touch are experienced by every single community, again, every single racial and ethnic community, but affects more marginalized communities. I already touched base on this, but I want to highlight it again because I think it's important. I have been increasingly talking about MAT as a tool for health equity. We don't do this for insulin. We don't do this for lisinopril. We don't do this for other medication. And it's because addiction has been seen historically as something different than a medical condition, leading to us and patients with OUD. And I would say us, I mean healthcare providers, whether you're a peer recovery specialist, or a social worker, a psychologist, counselor, PA, APRN, MD, researcher. We have that historical context in us. And even for me, I have done a relearning, right? I have done a lot of relearning. And I just want to point out that the majority of people do not use medication for opioid disorder. And from all addictions like stimulant, alcohol, cannabis, all of them, we have better medications for OUD. That's also for historical reasons, but the majority of people do not use it. And we know that methadone and buprenorphine reduce all-cause mortality by 50 to 70%. That's huge, 50 to 70%. We cannot say that from statins for cholesterolemia. We cannot say that from medication for diabetes. So buprenorphine has like a number needed to treat of two, meaning that you treat two people to have a positive outcome in that sense. And it helps not only decrease overdose risk, but also helps decrease risk of other medical conditions. And when I talk about treatment to people that want treatment or thinking about treatment, it's important that I educate them on different aspects of treatment. It's very typical for me that when I discuss medications for addiction treatment in the beginning, I ask them what they know, what they have tried, And when I introduce methadone and buprenorphine first, I explain how typically I started, in what dose, and for how long they should be on treatment. And I said that because we have data for opioid disorder that for methadone, for example, if you treat someone with methadone for 3 months or less, they do not have long-term benefits. You need to have someone in methadone for at least 12 months, 1 year, to see long-term benefits. And similar data has been seen for long-term use defined as more than 12 months for buprenorphine. So it's important to share that. In patients that tell me, but doc, I don't want to be long-term in medication. It's okay, but I need you to know that you need to be at least 1 year in treatment to have better outcomes. So in summary, when I think about medications for opioid disorder, I think about three things that I need to look for in good treatment. First, that the patients want to take MOUD, and that requires a level of understanding that they need the additional help. Second, initiating treatment, explaining the dose and how we might increase it. For buprenorphine, for example, there is increased evidence that 24 milligrams lead to better retention. Because I think when we were in the second wave of the opioid crisis, when we were like treating people with a lot of heroin use, even prescription, lower doses of buprenorphine, we're having people stable. And what I mean by stable is they didn't have withdrawal, they have less cravings, they use less or stop using. In the age of fentanyl, that is quite more potent, we have seen that there are needs of higher doses. And lastly, retention in treatment, how long they stay in treatment. And I already told you some perks that I use with my patients. Like I give them an expectation of how long they should be on treatment. The overall answer is as long as you need to. But for those that do not want to be long term, I typically ask them at least a year. Of all the categories I mentioned before, there are disparities, meaning like when we think about who access medication, who stays in the medication, what quality they get the medication, and I think about how long they are, what dose they have, there are disparities or inequities, right? And that has been shown in literature. So again, it's not only about starting the treatment, although that's one of the key ingredients, but it's trying to think how we can keep people in treatment, how we can improve quality, and how we can have them, like this is more not for MOUD, but completion of treatment, like inpatient, what can we do to help them complete treatments? And I think it's something important to mention is that there has been studies that look at completion of treatment and by race and ethnicity. And when they look at social factors that could be affecting completion of treatment, they saw that for Black and Latinos specifically, when they took the social variables from the way, there were no much disparities in completion of treatment. What that means is that the disparities were largely explained by differences in socioeconomic status. It could be housing or employment. What I'm trying to say is, it's not that American Indian or Alaska Native, Latina, Hispanic, or Black communities are using more substances than other people in all aspects. The blame is not on that social construct, is that there is a constellation of tentacles from structural barrier that put them at risk for more negative outcomes. When I think about what is equitable addiction treatment, these are things that I always keep in mind. First of all, it needs to be readily available. When I teach trainees on alcohol disorder, opioid disorder, for the majority of people, you do not need to get laboratory to start buprenorphine or even start naltrexone. We used to think that we needed liver function enzyme, like check the liver before starting naltrexone, for example. Now we know that we don't need to do it as a standard. Now we don't. Um, if there is clinical evidence of liver disease, and clinical evidence, I mean they're looking yellow, which means jaundice, or they have tremors from liver disease, that's different. That I would do laboratories. But again, for the majority of folks, we can start treatment right away. Second, we need to incorporate harm reduction strategies. And what do I mean by that specifically is we need to have an acknowledgement that there will be people that want to stop using the substance. There will be people that will reduce the use and might get to stop using in 5 months from now. And there's some that do not want to stop completely. They just want to reduce. And truly, all of them are progress. Ideally, you want someone to stop using, but if you help someone to reduce fentanyl use from a bundle to 1 bag per day, that's tremendous progress. If you help someone to smoke cocaine 3 times per week versus every single day, that's progress. Okay? And there are folks that might need more outreach support. It can be that you cannot do it, but you might want to ally with other community partners to be able to give that. It must also attend the multiple needs of the individual, not just substance use. Just to give you an anecdote, I work in street psychiatry, so I work in a team that focus on people that are on shelter with severe mental illness and that typically do not go to clinics or ED. And he wanted to get housed, but he had outstanding warrants. He also had stimulant disorder, opiate disorder, but for the first few months and first year of treatment, we work on addressing the warrants because at least in Connecticut, I know less of how that works in New Jersey. If you have a housing voucher, which is great, if you have outstanding warrants, you need to first present to court for the warrant, and they decide if you can just be released or the warrants can be vacated, or you need to go in for some time. And that is very scary for many people. So I work with a lot of people that might have a housing voucher, but because they have warrants, they cannot use the housing voucher. So we were able to have him trust on us to write a letter to request the warrants to be vacated. That successfully happened. That lead to him being able to use the housing voucher, and he started methadone in around that same time. So that was an example of how I needed to put some of my goals as a doctor on hold because the priority of the person was different. That's just an example. Treatment should be of adequate duration, and I already mentioned that for methadone, buprenorphine specifically, I tell people they need to be on that treatment as long as possible. And if they truly, truly, truly are hesitant about that, I ask them at least a year. And we need to include effective medications in our treatment planning. Methadone and buprenorphine are great treatments. It's not for everyone, meaning that not everyone wants it. But the data support how is very helpful compared to other medications for other treatments. And again, if you have a patient that could be a facilitator, peer specialist, and they don't use medications for opioid disorder, that's okay. It does not mean that it will work for a neighbor. Okay? And thinking about marginalized communities, it needs to be shared in a culturally responsive manner and linguistically sensitive service manner. So I'm getting to the end. I was told to have at least 15 minutes for questions. I know it's 11:47, so let me just go to the summary slide. 4 take-home points that I want you to take from this because I know it was a lot of data. First, opioid overdose deaths are decreasing nationally, but the decrease vary by race and ethnicity, with Black and American Indian or Alaska Native still having disproportionate impact of those deaths. There is a persistent increase in overdose death from stimulants without fentanyl. So death from fentanyl going down, but death from overdose from stimulants are not going down. And we will soon need to see how that continues to evolve. Thirdly, the drug supply is an important driver of racial and ethnic disparities in overdose death, but it's not the only cause. There are structural drivers as root cause of those disparities, and they need to be addressed. Otherwise, we're going to see similar trends in the future. And I'm honing that point a lot. Equitable addiction treatment for opioid disorder should include medications like methadone and buprenorphine because we have good data for it. With that, I thank you for your time, and I will make myself available for questions from the audience or just clarifications or conversation.
Thanks so much. I think your presentation was really insightful and very valuable to all of our attendees. So thank you for that. I know you spoke about medically assisted treatment, and you touched on cultural facets that may impact, right, someone accessing treatment. So one question we had in the chat was, how do we empower our patients to take a more active role in their recovery or
Mhm.
in their treatment journey?
Yes, I have two quick answers to that one. For the first answer, I will be vulnerable. You need to be patient, and that's hard for me. I remember when I was impatient, and a feedback that I always got was, Fabiola, you need to be patient. And that's hard for me because I feel I was failing because I was not helping that person get better. And I started to understand that just by having that person continue to see me, even if they were still using, that's still path for progress. For when they're ready to start medication for addiction treatment, I can be quick. And just because I saw it in the chat, what is different from MAT to MOUD? Because it's pertinent to what you mentioned. Those are umbrella terms. MAT is medications for addiction treatment. It used to be medication assisted treatment. And if I can, I want to say something. I know we're trying to change as a field to call it medication addiction treatment because we don't think these medications are assisting. They're just part of the treatment. Like we don't use lisinopril as medication assisted high blood pressure treatment, or we don't use diuretics as medication assisted for heart failure. So MAT is medications for addiction treatment. MOUD, so MAT talks about all medications for addiction treatment, like Chantix for nicotine, naltrexone for alcohol, is a big umbrella term. MOUD refers to the three FDA-approved medication for opioid disorder: buprenorphine, naltrexone, methadone, in all the forms. Because naltrexone comes in injection, buprenorphine is very well known as Suboxone. It comes in a film. It comes in a tablet. It comes in a weekly injection. It comes in a monthly injection. I just want to say that. So going to Angela's point, being patient. And second, something that has worked for us in the street team, the word from the street has more power than my word. What do I mean by that? We were able, may he rest in peace, Hippie, nickname Hippie, we were able to help one person get on long-acting buprenorphine called Sublocade. And the person did well. And Hippie spread the word in the unhealthy population that he's on Sublocade and it's actually working. After Hippie did that, I had like a group of 5 people in 2 weeks that told me, hey, what is Sublocade? I might be interested in that. I know a friend That study works. So I say that because I think one tool that can be used and has been used is having people in recovery or peer specialists help social workers, counselors, psychologists, doctor engage people in medications for opioid disorder.
I think obviously peer support's so important, and I don't think it's necessarily the first thing you think about, right, when you're talking about um, treatment and recovery. So I think thanks for
And
sharing.
if I
Yeah.
can add, many people don't do it in the first attempt, meaning I have people that have tried methadone 3 times, and it's on the fourth time that it really feels for them that they're being more successful. And it typically has to do that they have more stability in other areas. Maybe the first 3 attempts in methadone, they were unhoused, they had a lot of interpersonal problem with partner or things. And in that fourth attempt, they had less of that, and maybe they felt better emotionally, right? Or have a different mindset. So it's common multiple attempts at remission and treatment.
No, I think something that goes hand in hand with this, and I saw it in the chat, a question come up about the role of stigma from clinicians, stigma from families, stigma in the community.
And from patients too. We all have stigma,
Yes,
right?
yeah. Can you?
Sure. Um, so there can be a whole webinar about stigma, and it's very important. I will say we know now the different level of stigma. Individual stigma, you feeling that you are, and I will use a pejorative term, you're a moral failure, of someone saying, is his choice when we know it's not a choice. There is enacted stigma. That means discrimination. Someone that does something to you. It can be that a counselor says something negative to you, or me as a your psychiatrist say something that is hurtful, right? And you feel discriminated, and that leads to distrust in other providers, right? And you truly saying that you really need one night of sleep in a safe place, and you're told that's not it. That's not like minimizing. And there's even structural stigma that I think that's the one that is not spoken about a lot. For example, I can handle miditodimine. That's a new substance that is like very much potent and silencing. I can handle miditomidine and fentanyl test strips. That can be illegal in other states of the nation, right? Some people even consider that the way we have methadone set up in the state, in the nation, is part of structural stigma, which I believe too, right? So there are different layers of stigma, and something that has been said a lot too. There's not only stigma for addiction, there's a different type of stigma for treatment. That's a new phenomenon being studied as intervention stigma. Stigma to the evidence-based intervention for specific marginalized conditions. Like for example, and um, I know this will sound random, but I'm just putting an example. There's a lot of stigma for some treatments because some people see abortion as a treatment, right? There are some people that have stigma to HIV treatment. There's stigma to medications for opioid disorder, right? And that has been studied as a different phenomenon. Um, there has been study that look at community stigma to different intervention of opioid disorder, and one done with the healing community studies looked at treatments like methadone buprenorphine is being more widely accepted, but there are many community members and stakeholders that still carry a view of stigma to naloxone. Naloxone is the antidote for an opioid overdose, and it comes in different ways. It comes in an injection formulation. It comes in a nasal spray formulation that you likely know as Narcan, but there are many nasal spray formulations. The one that I have in my office is Padagis. Like the Narcan is the brand. Narcan is the brand. So I'm just saying that there are different formulations of naloxone. So all that to say that there's stigma to the addiction per se. There's different stigma to different addictions. I have people that tell me, oh, I use alcohol, but I don't use cocaine or so-called hardcore drugs, which I think is pejorative, but it's still addiction. It's still addiction. Patients see us differently, right? Um, so yes, like stigma is intertwined. Another structural example of stigma to addiction is not all psychiatric residency program. I know less of social work, counseling, or psychology. Not all psychiatry residency program have a dedicated curriculum of patient care plus theoretical of addiction. Most people get a theoretical knowledge on substance use disorder, but not all programs get the hands-on experience. That's a structural factor that leads to stigma because people know less, they do it less. So when they encounter it, they might feel less prepared and have more biases. It's just an example.
No, I think that's a great example. I know we're coming to the end of our time. We only have about a minute left. I want to mention to all of our attendees, I want to thank you for being with us today. I think that today's information was so important. I hope you'll join us on July 9th as we discuss treating pain after dental surgery. We had a really comprehensive long-term research project that was done by Rutgers University that we'll be sharing the information on the screen on how to get credits for today's webinar. And also, I know we have a lot of questions in the chat. You will be receiving a copy of the slides as well as a link to today's presentation by tomorrow. So take a look in your email from that. Again, thank you, Dr. Arabella Cruz, for joining us. Thank you for all of our attendees. And I wish everyone a great day. Hope to see you next month.